Dr.Bholesh Ratna Rai. He is a senior vitreoretinal consultant at DDEC, MBBS from Patna Medical College, MS from PDU GMC Rajkot, fellowship in vitreoretina and uvea from Arvinda Eye Hospital, a long experience, has multiple peer-reviewed publications in national and international journal, has served Indian Railway Medical Services and honored for starting ocular surgeries for establishment, has been a speaker and presented papers in many state and national conference. Above all, a very gentleman, and he's doing wonderful job with DDEC. So over to the OT. Can you give little bit of introduction about the case which is going to be operated?
Yeah. Thank you, sir. Good morning, everyone. So I am going to operate on a vitreous hemorrhage case. The patient presented, 42-year-old lady presented to us a few weeks back with loss of vision in left eye. On examination, we found left eye vitreous hemorrhage, and in right eye she had resolving vitreous hemorrhage. On history, she gave history of head trauma 2 months back, and on CT scan we could see resolving contusion in brain. So we made a diagnosis of vitreous hemorrhage in Terson Syndrome. On B scan we could see that is a blood stained PVD and a vitreous hemorrhage in core vitreous. Retina RCS complex, retinochoroidal complex appears to be normal. So we are starting with Constellation 25G vitrectomy system and 10K cutter. Switch off light.
A few postgraduates have also joined, so I'll request Dr. Bholesh to give the basics of vitrectomy also, because this is a core vitrectomy you are going to perform, and all the best for this surgical technique.
So she is a phakic patient, and in such a dense vitreous hemorrhage we need to be very cautious, because sometime RD can mimic like blood stained posterior hyaloid. So we will be a low suction and high cut rate, and just we will keep away from retina, and probably we will start our surgery in nasal side of retina, I mean nasal quadrant, so that even if underlying retina is detached, but we will be safer side. Am I audible clearly? Am I audible clearly?
Yeah, clearly audible. And we have with us Dr. Deepak also Agrawal has joined. So I think we will not come in between Dr. Deepak Agrawal and you. Rather, you two will be guiding the whole surgical session which you are doing right now.
Yeah, here I could see some gusts of old blood coming from retrohyaloid. So I have breached posterior hyaloid, I think. I will be very cautious, because such dense vitreous hemorrhage can have many underlying surprises. Yeah, now I can see retina.
$42 years.
So Bholesh, there was an incomplete PVD in this case?
Actually, sir, it was a complete PVD.
Okay, but the B scan appears like there's attachment in the towards the disc, is it? Or
Yeah, it is attached. Yes, sir. It is a incomplete PVD with attachment at disc.
Yeah, so it's an incomplete PVD, yeah. Okay, and
So it is a phakic patient. So I will switch my hand for trimming other side vitreous to avoid lens touch. Is it okay?
attachment of the posterior hyaloid actually. Yeah, so he has trimmed it at the disc. You didn't want to pull that attachment at the disc?
I will just trim it, sir. I won't pull it.
Okay.
Although we can pull, but I don't think it is necessary. It can remain like that only there.
But what will be the harm if we pull it? You think there will be bleeding from the disc?
Yeah, it is possible, but since it is a Terson Syndrome VH, and in Terson Syndrome usually the peripapillary capillaries bleed. So disc and disc vessels usually remains normal.
Yeah.
So there is no harm in pulling that, but there is, I don't think is there any additional advantage of pulling that. So if it is not advantageous, then better we will not insult tissue.
Okay.
थोड़ा लाइट बढ़ाएंगे.
So now you are trimming inferiorly, or we are not able to actually see properly?
Yeah, inferiorly I have done.
Okay.
Just I am trimming temporally with
temporal. Okay. Yeah. Yeah, we can see the macula here.
yeah. So in Terson Syndrome, we had a plan to see periphery, and I don't find any peripheral lesion, so I am not going to do any additional procedure like Indo laser and all that. PVD is also good and no treatable lesion, so I will do now FX.
And what about the peripheral dissection you have done? Or do you think you want to do a peripheral dissection also for a complete?
Sir, in such cases I feel we can leave bases.
Because you have not put a belt buckle also, I think, because it's a case of trauma and a young patient.
Sir, but
so do you think,
sir, actually in Terson Syndrome there is no ocular trauma, sir.
Yeah.
So I feel that any unnecessary, we should avoid any procedure which is going to give us any additional benefit.
Okay.
So like just we are doing a core vitrectomy, we should go ahead with like that.
Okay, so you think that peripheral dissection is not essential in such cases?
Yes, sir. Yes.
Okay.
Even in such cases we can do partial FX and leave FX on. FX on.
Two months. I think color is okay, sir, because there is engorgement of
Hello. Bholesh, in case we pull that stump sometimes and there is bleeding. How do we control that? Like, what are your options?
Excuse me, sir, I could not get.
In case we pull that optic nerve at stump and there is bleeding, what do you do to control that? Like,
Sir, like first of all, we raise our intraocular pressure. Even if that doesn't work, then we can do FX, or even if that doesn't work, then we can use PFCL. Even if that doesn't work, then at last option is that do FX and immediately put oil.
yeah. And I think
Oil or gas? We can put gas also, no?
Yes, sir, we can put gas also.
there are some people who do cautery over it, so I think
Actually, sir, I feel cautery over disc we should avoid.
Yeah.
so that's the message I wanted to send to the house, that we should never attempt a cautery or over
Yeah.
the optic nerve head, because that will cause
Like,
deleterious effects.
like in sometimes, like when we operate on CRAO patients, when we need to tug disc vessels very vigorously sometime, in that cases I have faced when sometime I had to use cautery. But in CRAO, since it is already a I mean very poor prognosis case, that we need to do sometime. Otherwise, in normal cases where we know prognosis, where we know result, so in those cases we should avoid cautery over disc or any major vessel. So FX done, patient case went very smoothly. We did not get any surprises.
Very nice, Bholesh, very well taken up, and it's good that, this patient probably will get 6/6 vision, and so in retina nowadays we do get 6/6 vision, and cases like this, they are pretty simple and doesn't cause much of a problem. Cases like Terson Syndrome, you can just do what Bholesh has done and probably just taken 15-20 minutes, not more than that. Thank you, Bholesh.
Yeah,
Very nice, Bholesh. Congratulations.
Thank you, sir.
Completing it very nicely. Yeah.
When we intervene such type of cases?
Yeah, since it's a case of trauma, Terson's syndrome, there's, there's hemorrhage in the brain also, there's vitreous hemorrhage. So once the condition of the patient stabilizes, and we see that the vitreous hemorrhage has not resolved over a period of 1 month, then I think there's no point in waiting. As you can see, the color of the blood has also changed so much, like from red it has become dark brown.
Ointment.
So it's not going to resolve on its own. So definitely, I think after waiting for 1 month, there's no point beyond waiting that. And once the systemic condition of the patient stabilizes, we can undergo, the patient can be taken up for surgery. As you have seen that it's a very simple vitrectomy which needs to be done. Only thing is, yeah, this is, if there's an associated retinal detachment, then probably, and like Bholesh said, like in Terson syndrome, there is no ocular trauma as such. So the risk of retinal detachment itself is very low in such cases.
Yes.
Terson syndrome usually doesn't resolve on its own, sir. So it needs to be taken up surgically.
Sir, regarding that stump bleeding, I want to add something. It's very important to know the blood pressure of the patient. Like sometimes we take the pressure to 60, it doesn't stop. Once the pressure is high, the marginal pressure is actually at the higher level. So you have to sometimes take it at 80 or 100. Many a times we have to take it up to 100 to take the control the bleeder. Also, I don't know what you
depends on the machine how much pressure can be raised.
And also
so
that
in Constellation, how much is it? Like
up to 120 we can
120.
take. Yeah.
Okay.
And other thing is we can also put a direct pressure on that if it's not under control, even at 100.
So how do you give the direct pressure?
Just take the pressure to 100, and if the bleeding doesn't control, I mean oil and other things I consider very late.
And I think oil, we shouldn't put oil just to control the bleeding. I think if you just put gas, sometimes what we have seen that, in PDR cases or something, if there's a lot of bleeding, you can put in C3F8 gas and leave it for 2-3 days. The bleeding will be stopped, and you can retake up the patient after 2-3 days also, if the bleeding is too much.
Maybe my
Secondary-
preference is while actually in PDR cases. Even if
No,
there
no,
is bleeding.
if the bleeding is,
Yes, sir.
not stopping.
Okay, okay.
You can also leave PFCL
Because-
and then come back, sir. You can also leave PFCL and then come back in few days. That also gives a very good result.
Audio is not clear.
Increase the pressure 200, there might be the question of visibility. Increase the
Audio is not clear. We will go there.
Up to 6 minutes, there are literatures on this. Up to 6 minutes, we can keep the pressure till 100. Not 200, it's 200, sir. And we don't keep it continuously. We
Intermittently
keep
you have
60, 30, 60, 30. We keep on alternating.
The machine will also give you a beep, like after every 30 seconds, I think it gives 1 minute.
Constellation, it's 1 minute.
Okay.
Speaker. So any question?
So Bholesh, I just wanted to ask you, since this was just a Terson syndrome, but if there was vitreous hemorrhage in vasculitis patient, so would you prefer putting a belt buckle in such cases in a young patient with vasculitis with just vitreous hemorrhage?
No, sir.
With some,
If in such cases, just I will add endo laser on area which is affected by vasculitis, and if I see any NV, then I will laser all those around areas. Just that is the additional procedure I usually do. I don't put belt buckle if retinal detachment or I feel it is if any tractional component is not there. I mean, belt buckle role in such cases is just to do base trimming without touching lens. I mean, it will give us just an extra edge. So, I don't think we need to do belt buckle in cases of vasculitis if RD is not there.
Okay.
I think Deepak sir, you
Sir,
want to...
for belt buckle, it's very important that we do a good BS scan preoperatively. Anything anterior to the muscle insertion, any traction or it's better to put a buckle. So the BS scan plays a very important role. And it's important that we preoperatively look for the any peripheral traction which is going beyond anterior to the muscle insertion. If it's there, it's better to put a belt buckle because it's very difficult in vasculitis cases to
Because
pull the very
I
difficult.
also
And in
seen
cases
so
of
many
trauma
cases, it happens like a simple vitreous hemorrhage, vitrectomy has been done, gas has been put, and for a month or two the patient will be fine. But after 4 to 5 months, there will be so much of traction that there will be a redetachment.
And many comes with that detachment. Yes.
Especially in young patients.
Yes,
So I preferably feel that putting a belt buckle in a young vasculitis always helps.
And sir, how do you decide when to inject anti-VEGF in these vasculitis VH cases in young patients?
See, if the patient has not been lasered any time and I see a lot of fibrous proliferation, I would prefer giving anti-VEGF and do it after 2 to 3 days. There's no harm in giving an anti-VEGF.
So you wait for 3 days.
Yeah, I wait
sir.
for 3 days.
3 days.
3 days only.
And in diabetic VH cases, how long do you wait?
I think the second
2 to 3
case
days.
is, sorry to interrupt, the second case is Dr. Ranjan Rai. So when OT is ready, we'll stop the discussion on vitreoretina's part and then we'll move on to phacoemulsification and anterior segment surgery. In the meanwhile, Dr.